Hello and welcome to our new topic. Today we will discuss the pharmacological treatment of inflammatory bowel disease, which is not merely a group of gastrointestinal disorder. It is fundamentally an immune-mediated inflammatory disease. Therefore, management requires modulation of immune pathways rather than simple symptom relief. Understanding this topic requires integration of immunology, genetics, and pharmacology. So, let's start. The intended learning objectives are shown. IBD begins with disruption of the intestinal mucosal barrier. Normally, the epithelium prevents bacterial invasion. When this barrier fails, luminal antigens activate the immune system. This leads to chronic inflammation. Therefore, all therapies aim either to suppress inflammation or restore immune balance. Mucosal inflammation can be divided into two categories with respect to effector versus regulatory T-cell balance. In the first type, effector cell responses, either T helper 1, Th1, or Th2 cell responses, are abnormally robust and the intrinsic homeostasis of the mucosal immune system is biased towards inflammation. Alternatively, effector cell responses are normal, but regulatory cell responses are weak. Again, inflammation is the result. This slide highlights the genetic predisposition. Certain individuals have abnormal immune regulation. Genes like NOD2 alter bacterial sensing. As a result, the immune response becomes exaggerated and persistent. This explains why IBD is chronic and relapsing. The innate immune barrier normally protects the gut through mucus, epithelial tight junctions, and antimicrobial peptides. Failure of this barrier allows bacterial products to penetrate, triggering inflammation. So pathology begins at the mucosal level, not systemically. The innate immune system is currently seen as the likely initiator of the cascade of events which culminates in Crohn's disease. This shift in focus is in part due to the identification of NOD2 as a gene associated with Crohn's disease. The precise understanding of the aberrant innate immune response is uncertain. The components of the intestinal innate immune barrier are multiple and include the intestinal bacteria themselves, the biofilms, circulating elements such as complement, and numerous cell types including the epithelial cell, neutrophils, macrophages and Paneth cells among others. The cellular products are listed by the cells of origin. NOD2 normally senses bacterial components. Mutations impair bacterial clearance, causing persistent immune activation. Hence chronic inflammation develops. This is an example of genetic susceptibility leading to disease. Crohn's disease is mainly Th1 mediated, with cytokines like TNF-alpha and interferon gamma. Ulcerative colitis tends to be Th2-like. This difference explains why some drugs work better in one disease than the other. Therefore, cytokine biology directly guides pharmacology. Trinitrobenzene sulfonic acid, TNBS, and oxazolone, both classic skin sensitizing agents, give rise to different forms of colitis when administered intrarectally in experimental animals together with ethanol, an agent that temporarily decreases the function of the epithelial barrier. These colitides are strain-specific and genetically determined. TNBS elicits a classical T helper 1, Th1, cell response owing to interleukin-12-mediated production of interferon by CD4 plus T cells. The result is a transmural inflammation that resembles Crohn's disease. By contrast, oxazolone induces a Th2 cell that is mediated by natural killer T cells that produce interleukin-13. The result is a superficial inflammation that resembles ulcerative colitis. This demonstrates that specific immune pathways cause tissue injury. Blocking these cytokines becomes a therapeutic target. This is a key conceptual slide. It shows where drugs act: mucosal inflammation or cytokines or immune cells or signaling pathways. Every drug we discuss today acts somewhere on this pathway. Always ask, which step is being targeted? Depicted here is a generalized pathway of the mucosal inflammation underlying inflammatory bowel disease and potential points of therapeutic intervention marked as A, B, C and D. A. Secretion of inductive cytokines, such as interleukin 12 or 13, can be inhibited with nuclear factor B, NFB, inhibitors or, more specifically, with various cytokine-specific monoclonal antibodies. This can occur in the mucosal follicle, as shown, or at more downstream sites. B. The traffic of effector cells into the lamina propria can be blocked by inhibitors or monoclonal antibodies specific for integrins or chemokine receptors involved in homing. C. Tumor necrosis factor expressed on the surface of effector cells can be cross-linked by antibodies specific for TNF, leading to apoptosis of effector cells. D. Regulatory T-cell induction or function could be enhanced so as to counteract effector T-cell function. This can be achieved by the delivery of vectors encoding regulatory cytokines. Treatment includes anti-inflammatory drugs, immunosuppressants, antibiotics, and biologics. Therapy escalates based on severity. This stepwise approach minimizes toxicity while maximizing control. For mild disease we use aminosalicylates. Moderate disease requires steroids. Severe or refractory disease requires immunosuppressants or biologics. This stepwise approach reflects increasing immune suppression. Aminosalicylates act locally in the colon. They inhibit prostaglandin and leukotriene synthesis, reducing inflammation. They are first line in mild ulcerative colitis. Because they act locally, systemic toxicity is limited. Steroids are powerful anti-inflammatory agents. They suppress cytokines, leukocyte migration, and immune activation. They induce remission rapidly but are not suitable for long-term use due to toxicity. Azathioprine and 6-mercaptopurine inhibit purine synthesis, preventing lymphocyte proliferation. They are steroid-sparing agents used for maintenance therapy. Onset is slow but long-term benefit is substantial. Cyclosporin or tacrolimus inhibit calcineurin and block T-cell activation. They are reserved for severe, refractory disease. Toxicity limits use. Please check the lecture on corticosteroids, immunosuppressants and immunomodulators for details of those drugs. Adverse effects include rash, hepatitis, bone marrow suppression, and hypersensitivity. Many are due to the sulfapyridine component. Therefore, mesalamine is often preferred for better tolerability. TNF-alpha is central in Crohn's inflammation. Monoclonal antibodies like infliximab and adalimumab neutralize TNF. This dramatically reduces inflammation. These drugs revolutionized IBD therapy. By blocking TNF, these drugs prevent cytokine cascades, reduce leukocyte recruitment, and promote mucosal healing. However, immune suppression increases infection risk. Newer agents target integrins, cytokines, and signaling pathways. These represent precision immunotherapy. Pharmacology is moving toward targeted biological modulation rather than broad suppression. Potential therapies in IBD encompass interventions at a variety of pathways in the inflammatory cascade. These include altering luminal factors, enhancing intestinal repair, augmenting the intestinal innate immune barrier function, inhibiting cell adhesion and blocking cytokine activity. This slide reinforces the centrality of TNF signaling. Blocking this pathway interrupts inflammation at multiple steps simultaneously. Tumor necrosis factor is a central cytokine for inflammatory bowel disease and a prime target for existing therapies as well as those under investigation. Agents are being investigated which block TNF action at a variety of key points, including upstream cytokines that direct transcription as well as metalloproteinases that cleave TNF from the cell surface, in addition to more familiar approaches such as monoclonal antibodies that bind to TNF. This slide reviews the older, conventional drugs, generally effective in mild to moderate IBD. This slide reviews biological agents currently in use in moderate to severe IBD. This last slide reviews additional biological agents not in widespread use as yet, but provide an additional group of effective drugs especially in moderate to severe IBD. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!